Hello everyone, I'm Dan. I'm a person with lived experience of mental ill health. I have a particular interest in suicide prevention and I live in Cheltenham in Gloucestershire. I've been asked to speak a little bit about myself and then about the work that I do and then about how librarians can help me to do that more effectively. Now, I left school without any qualifications. I've got a grade 1 CSE in drama and a grade 5 CSE in home economics. I didn't do A-levels and I haven't been to university. When I look at what a typical day for me is, well, it's a bit tricky because I don't actually have one. At the moment I'm not employed, so I do something called service user participation. This is sometimes called patient and public involvement, sometimes it's called co-production. These three things are fairly similar. They do have some slight differences though. Until very recently, my focus has been on mental health, safety and quality improvement. But I'm trying to expand that out into physical health as well. The service user participation that I do is for different organisations. So I'm involved with things for my local mental health and community care NHS Foundation Trust. I'm doing something about community mental health transformation with a local charity. I do bits and pieces for my local clinical commissioning group. Before the pandemic, there was a regional patient safety thing for the south of England. And I've just been doing a short piece of work for NHS England and NHS Improvement. And I've just applied for that long term, so fingers crossed. Now, none of this is patient facing. I tend not to talk to patients. It's all on the bureaucratic side of things. The work that I do has got two main components. So the first will be holding an organisation to account, and it's to make sure that they're including the voice of the patient and carer in the work that they do. The second piece will be around the longer term work streams that are trying to reconfigure a service or to implement a new service. But the way I work for both of these is fairly similar. Most of the work I do is done in meetings, so people will send me through the papers and I will set aside a day to read through all of them. As I'm reading through them, I'll make notes of the things that I don't know yet. I think that framing is quite useful for me, because if I've got a big long list of things I don't know, quite demotivating. But a big long list of things that I can look up is a bit more optimistic, I think. So I've got a list of things that I don't know yet. There's a list of things that I'm finding a bit confusing. Sometimes I will know the topic in the paper quite well, and the paper will have presented data in an unusual way, and I want to know why that is. I'll also be building up a list of questions that I want to ask. So when I finish going through the papers, I've got a list of things that I want to look up, a list of questions that I want to ask, and I'll go to a search engine, start working out how to ask the questions that get a good answer. People say there's no such thing as a dumb question, and they're right, but there are questions that don't give useful answers. And this is where things start to get a bit tricky for me. I'm outside the NHS and I'm not a member of any professional body, and this means that I'm not as familiar with the sources, and I don't know which are reliable sites to use, and I don't know which are less useful. And so I do have to spend a bit of extra time checking the sites that I'm using to find out if they're sensible or if they're nonsense. Once I've gone through my list, I've learned a bunch of stuff that I didn't know before. Some of it is useful to me only for that meeting, and I don't need it afterwards. But there's some things that I do need to remember, so I've got a complicated system of personal notes where I put things with definitions and links to more sources of information, and I try and put that into the wider context of the stuff that I'm doing. I've also by now cut my list of questions right down, because I will have answered many of them just from searching the web. So I've got some questions left, and I'll split those into three lists. So the first is a list of questions that I think I can answer myself. The second will be questions that I probably need to ask somebody. This is quite an informal question that I can just ask in a coffee break. And I think when we're having lots of these virtual meetings, those coffee breaks are quite crucial bits of work that we're losing out on. The third list will be questions that I want to ask during a meeting. And these will tend to be the holding an organisation to account type of question. Sometimes for these, I will already know what the answer is, but I need to get my question and I need to get their response into the record. So for this third list of questions, I need to know what the law says, what the statutory guidance says, what current best practice is. I also need to know what the emerging themes are, and I need to know what patients and carers have to say about it. So patients and carers, I talk to a wide range of people, and I try to keep up to date through conversation. If I look at the law, it's quite tricky. I mean, that's why we have qualified registered professionals who offer quite expensive legal advice. So we have acts and statutes and statutory instruments and case law. They're written in very careful legal language, but they're also scattered all over the place. It can be really tricky to find the relevant statutory instrument unless you know what it is. Statutory guidance and best current practice does tend to be much easier to find, much easier to understand, because people want you to use it. They want you to find it and they want you to follow it. But again, there's not a central location for it all, so it can be all over the place. All these different organisations have their own websites and they've got very different navigation systems on their websites. And they use slightly different language to describe their best current practice, so that can make it difficult to find. The thing that I struggle hardest with though are the emerging themes. And that's because they tend to be academic research, so they're behind a paywall and they're written using language in new and exciting and unexpected ways. I want to point out, gently and kindly, that sometimes academia, it feels like academia can hamper a person's ability to communicate in plain and simple language. Maybe I'm being unfair, but if there is one thing I could ask of universities, it would be to encourage people to use fewer words and to use simpler words. So anyway, when I found these sources, I'll put a link to them in my notes, and then I'll link to the paragraph. I'll cut and paste the paragraph that's most relevant to the point I want to make, and then I'll spend a bit of time rewording the questions that I want to ask to make them as concise and clear as possible. And the reason I do that is because I don't want to give people any wiggle room. When I ask a question, I've normally got an answer in mind that I want them to give, and I want them to give that answer. I don't want them to be able to say, oh, let's answer a different question. So I've been asked to give a few examples about the data and the information that I use, and it's in suicide prevention. So I'm not going to go into too much detail because I'm cautious about just dumping this on people if they're unprepared. But I use the statistics and the research from an organisation called NCISH, which is the National Confidential Inquiry into Suicide and Self-Harm. And I bring that information back to Gloucestershire to support the work that I do. I think people can be a bit surprised that in England we have 3 different definitions of suicide, and we pick and choose the definition that we use depending on the context that we're in. So there's the definition used by coroners, there's the definition used by official statistics, and there's a third definition used by public health. We talk a lot about jargon, and sometimes people think that means the complex Latin words or the unexpanded initialisms. Now those are problems, but to me the wicked jargon is the normal English word to which we give a weird specific meaning to. There's loads of examples of this in mental health care. and probably in other healthcare as well. I mentioned earlier that I'm trying to expand my knowledge from just mental health patient safety into physical health patient safety, and one of the areas that I'm looking at is pressure ulcers, especially hospital acquired pressure ulcers. And blimey, I was not prepared for those images. Really quite graphic images of wounds, presented with no warning at all. I'm making light of it here, but clearly those are important because people are suffering, and we do need to do more to prevent that harm from occurring. But it's just a surprise that there's a difference in the way information is presented. So, as I've been speaking, you've probably been thinking, yes, Dan, this is what librarians do. We help you understand the questions that you want to ask. We help you find the good quality sources. We help you find the information. We can unlock some of those paywalls. Librarians help you get the good stuff. And you might be wondering why I haven't mentioned librarians yet. So one of the questions I've been asked to think about for this talk is how librarians can help people with lived experience make best use of what's available. It's actually quite difficult for me to talk about this, but I'll give it a go. Most of the professionals I work with went to university, they got degrees, lots of them went on to get masters, and they work within an organisation, and they're probably a member of a professional body. They feel very comfortable using a library. They know it's there, they know it's available to them, they know how to use it, they know what it can do and what it can't do. I don't have any of this. People talk about imposter syndrome, and that's writ large for me. I can feel, because none of the stuff I do is going to get published, I can feel that I'm not doing proper research. I can feel like I'm just noodling around, getting bits and pieces of data from here and there. And because of this, I can have a distorted thought that perhaps my query isn't worth taking up a librarian's time for. The other part of it for me is that I can really struggle to use something for the first time. That first step through the door can be disproportionately difficult for me. But once I've done that first time, it's a lot easier for me. So, speaking just for me, to help me use library services, I do find it helpful to know that they're available for me to use, and that there are expectations around what I can and can't do with them. And this piece about setting expectations is to help ease my anxiety. I may think that I'm using too much service, and that anxiety is eased if I can see that you've set a limit for what is reasonable, and I can see that I'm nowhere near that limit yet. There's also a thing about fixing that first use problem, and that could be a very simple 5-minute appointment. So I set an appointment time to meet somebody outside the library. I turn up and they meet me, and then we walk through the door together, and then they spend 5 minutes just telling me how things work. And that for me would be enough. I mean, the other thing, and I'm sure you're all lovely people, so this is going to be really easy for you to do, it's just some reassurance that it is okay for me to be using the library. I think there's something there about permission to do things. Now, those are the things that work for me, but of course other people aren't me. There's a wide range of different people. So at one end, you've got people who've got a lot of familiarity with the library. They know what they are and how they work. At the other end, and I'm struggling a bit with the language here, and I'm sorry if I'm getting the language wrong, but there are people who've got low levels of literacy. So they may have an undiagnosed reading disability, or they may have missed out on a lot of schooling, and they may struggle to read. As you will know as librarians, some people are very open about this, and some people keep it quite hidden. I have noticed that librarians are very keen to help support people, and I've noticed that librarians use innovative ways to provide support that focuses on what a person actually needs. So for a librarian, there's no one size fits all. There's not a blanket approach to helping people get reading. You really do look at what people need. And that's something that I try and take out into healthcare. So I'm going to try and summarise what I've said here. Service users and carers can be involved in a wide mix of different activity, and each individual can be doing quite an eclectic mix of activity. We may not be as familiar with good research habits, and we may not know what the reputable sources are. And once we found a source, we might not understand how to test it, how to prod it and poke it to see if it's a good source or not. Sometimes we can build up expertise in a particular topic, and to other people this expertise can simultaneously look a little bit shambolic because it's self-guided, but also quite impressive. Finally, I want to end on a point about co-production. So co-production is important, and that's not just me talking to you, but it's about you talking to people in your local organisations. I think many organisations have a service user group, and it's probably quite handy if you can arrange a meeting with that group to talk about how you can support people with lived experience to make use of the library. So I'm going to finish here. I want to thank you very much for your time and for the invitation. I just want to mention briefly that because of pandemic, this talk has been put together at the last minute, so it's a little bit more all over the place than I would usually like, and I apologise for that, but I hope it hasn't been too rough. So anyway, thank you very much. Bye bye.